Can you see that it's recording or not?
Yeah, it's started.
Yeah.
Yes, it's recording.
So I'll quickly go through the first lecture. Do you want me to do that? I mean, first slide. Do you want me to do that? Or can I just continue? Come on. I'll just go through the first slides.
Continue.
Right? Okay. Okay, this lecture is on applied pharmacodynamics 1, and of course there's a pharmacodynamics 2, and we've broken up the whole chunk of pharmacodynamics into 1 and 2, just like your pharmacokinetics, right? And so as I said earlier, this lecture is all about knowing how mechanisms of drugs, how they work. I've always wondered, as I said, I've always wondered how do these drugs, when we take them for blood pressure, when we take them for a headache, we take them for something else, how do they know what to do? We still don't know how they act, but we do know most of the actions now, at least some of the actions, all right? So applied pharmacodynamics 1 will take you through some terminologies and so on and so forth. And by the way, I've not met you all, but I am Professor Dr. Nafiza Muhammad Ismail, and I'm a professor of pharmacology, clinical pharmacology. I was the dean for School of Medicine until February this year when I finished my tenure and decided to step down simply because I wanted to concentrate on teaching as well as research. Well, like you can see, I'm also the president of the Malaysian Society of Pharmacology and Physiology, and I was also the former dean of a public university. All right. So we have four LOs, and we'll talk about the definition of terms such as pharmacodynamics, what receptors are, what endogenous ligands are, what drug receptor interactions, what do they mean, terminologies, definition of agonists, four mechanisms of drug actions. That's really connected to LO3, because when we talk about the four mechanisms of drug actions through receptors, we have to talk about the four main receptors of families of receptors, which is LO3. So LO3 is very much connected to LO2. The difference is LO2, we will also talk about the other three mechanisms of drug action, which is carriers, ion channels, and enzymes. And the fourth and last LO is explain the process of receptor regulation and functions of receptors. Okay. So this is the definition, which is your lecture or LO1. And so I've put it as numbered them as A to H so that it will be easy for you to follow the definitions, right? Now, essentially, pharmacodynamics, you've gone through your pharmacokinetics about how our bodies handle the drug, how we absorb them, how we metabolize them. If they are prodrug, we have to activate them through the liver and so on and so forth. What we do to the drug. Pharmacodynamics essentially is what the drugs do to us, right? That's simply said. So it includes, as we said, receptors. Effectors are the organs where the receptors are located. It includes agonists, antagonists, and other types of agonists, and signaling mechanisms that occur in the cell, and receptor regulation. So all these items constitute pharmacodynamics. You will learn about this dose response curves tomorrow. Tomorrow, I'm not sure when, but I think it's tomorrow by Prof. Igor. All right, pharmacodynamics, effects of drugs and their mechanisms of action. Of drugs used in the treatment of hypertension, like calcium channel blockers or other things, you have to describe what happens in the cell, the cellular changes that occur. Okay, that is the mechanism of action. So everything that happens in the cell will lead to effects on organs. So you see pharmacological effects on organs. So drug mechanism of action is what happens in this at the cellular level, and that will produce effects on organs. For example, you'll get relaxation of smooth muscle cells, and that gives you vasodilation. And when do you want vasodilation? When you want to have a drop in blood pressure. All right. If the patient is hypertensive, you want to have a drop in blood pressure. So this is just one example that I'm giving you. All right. So mechanism of action, again, cellular changes, gives rise to effects on organs. The organs here are the vascular smooth muscles, or the vascular in the patient that you're treating, and you record his blood pressure. It was very high at one time, and now it's back to normal, or at least there's a decrease. What are receptors and endogenous ligands? Ligands are actually anything. Ligands are anything that can bind to a receptor, full stop. Endogenous ligands are neurotransmitters and hormones, right? So drugs are also called ligands, but of course, obviously they're not endogenous because they're exogenous. We have to take them in. So let's see what endogenous ligands do. And you know why we have to know this is because no drug can produce a new effect in a person. It actually modulates what an endogenous ligand does, right? So this is, let's pretend this is the endogenous ligand. And what are receptors? They are mainly molecules, and they can be found on the shape thing depicts a receptor, all right? So when the ligand connects itself, binds, the word we say is binds, not connect. When it binds to a receptor, okay, it produces a response, all right? So if there is drug interaction, drug receptor interaction, only then there will be a response. So when we talk about endogenous ligands, neurotransmitters, I'll use the example of adrenaline. Adrenaline is a neurotransmitter. When it binds to its receptor, there will be drug receptor interaction, and drug receptor interaction is nothing difficult. It just means that the ligand can activate the receptor. That's all it means. When the receptor can activate the receptor, we call it drug receptor or ligand receptor interaction. Only when there's activation or stimulation, a response. Okay, so that's activation for you. So let's look at the example. Now, certain conditions, okay, we need catecholamines. Adrenaline, as I said, I'll use neurotransmitter, adrenaline as an example. And catecholamines, adrenaline is a type of catecholamines. So certain conditions require adrenaline to be released to increase the heart rate. Okay, we want the heart rate to increase. And the example that I want you to look at the example here. So when the heart rate is increased, okay, when the heart rate, why we want the heart rate to increase sometimes is because the body recognizes that there is vasodilation. When there is vasodilation, the BP drops. Are you following me so far? Can someone answer?
Yes,
Yes.
Professor.
All right, that's good. So this is really physiology, okay? It's not pharmacology yet. When we get up from, when you are lying down and you get up from bed and you get up from sleep, there is vasodilation. And so all your blood will come down to your feet, and you may faint. So the body doesn't want that to happen. So what the body does is it releases catecholamines, and it causes vasoconstriction, and the BP rises again. Okay, so that's one example of why we need catecholamines to bind to the receptor. One of the reasons is we want to reduce the drop in too much drop in blood pressure. So drug receptor interaction. So this is the endogenous ligands. Remember, I said that the drugs do not produce any new action. We just can't do that. We always modulate whatever physiological actions that are already in existence in our body. All right. So EL is endogenous ligand. Endogenous ligands, say adrenaline, it will not be able to bind to the receptor. Why? Because a drug, another drug is around in its area, in its vicinity, and the drug competes with endogenous ligand to bind to the receptor, and it wins. Okay, it wins. It gets to combine. The drug it gets to bind to the receptor. So that drug binds to the receptor instead of the endogenous ligand. So now
Excuse
the
me,
drug.
Professor.
Yes.
Your voice has been cut off sometimes.
Oh, really? Eh?
Yeah.
Thank you for telling me. Just I'll bring my computer closer. Is it better now?
Not always. Like your voice just cuts off and then it comes back.
That's bad, isn't it? Anyway, if it gets too bad, then we'll have to shift the lecture. You. All right. Is that fair?
Yeah, it just broke off again.
Yeah.
Sorry, Professor, it just broke off.
So what do you want me to do now? Do you want to reschedule the lecture or shall we try to go on? I'm putting my face very near the microphone and I can't see the slides now. But can you hear me?
I can hear you, but I think it could be a condition with your internet.
It's just
Maybe it's a condition with the internet, doctor.
yes, doctor.
Yeah, but you know what? My daughter is in the other room and she's got no problems with the internet. So anyway, I'll just have to continue the lecture. And remember, I said if you want me to repeat the lecture, it's not a problem to me. I'll be more than happy to do it. Is that fair?
All right,
Yes,
Professor.
doctor.
Yes, doctor. Thank you.
Drug occupies the receptor. The drug occupies the receptor. It blocks the endogenous ligand from binding to the receptor. Can you see that? All right.
Yes.
So there will be no drug receptor interaction. So there'll be no response. Okay. Now students wonder why do we say there's no response? Because the drug actually binds to the receptor and you get a response. You actually don't get a response. You actually block the response of the endogenous ligand. And so that's why we say this drug is a blocker. It's an antagonist. Because when an antagonist binds to a receptor, it does not stimulate the receptor. Hence, there's no response being produced by the drug itself. For example, say you have a situation. Imagine a situation when there's no endogenous ligand and you have this blocker because it does nothing. It just sits there, occupies it. Are you following me?
Yes, doctor.
Thank you. So sometimes when the heart rate is too fast, just now remember we gave adrenaline. The body produces adrenaline and wanted to increase the heart rate. So it gets too fast. Okay, sometimes there's tachycardia, which is increase in heart rate. Then we give drugs to block the actions of adrenaline like this. We want to block the actions of adrenaline so that the heart rate will drop. So no drug receptor interaction, so no response. This is an example of an antagonist. So now we come to the various terminologies, which is agonist, full agonist. So these are drugs that bind to receptors. Remember, all these drugs, whether they're full agonist, partial agonist, inverse agonist, antagonist, they can all bind to the receptor. Okay. Let us see agonists first. Now, agonists are ligands. Okay, agonists are ligands, which are substances that interact with the receptor. They not only bind to receptor, but when they bind, they stimulate the receptor and they activate the receptor to produce a response. Okay. For example, this is what I've said earlier, but this is to emphasize more. So this is a drug A. This is not a drug A. This is drug A, and drug A is a full agonist. When it combines with the receptor, when it binds to the receptor, it produces a response. And why we put effector here is because this cell is situated on an effector organ. Other examples, the kidneys. Other examples, the vessels. So the effector organs are many organs in our body. All right. So drug A binds to a receptor on the cell, produces a response. Why can it produce a response? Because it causes stimulation of the receptor. If it does not cause stimulation, it will not cause a response. Right? So again, remember people, affinity means ability to bind to a receptor. It doesn't tell you whether it activates or stimulates or interacts with the receptor. It just means it simply binds to a receptor. Efficacy, however, relates to the fact that it activates the receptor, right? If there is no activation of the receptor, we say the drug has no efficacy. Now, right now, what drug what sort of which of this following? No, not yet. Okay, we'll go on and see whether you know later. All
Sorry,
right.
doctor. I
Sorry,
think
doctor.
got cut off when you asked that question.
Get your
Could you
question,
repeat?
doctor.
Oh dear. Okay, I said of all these slides, full agonist and antagonist, which one has affinity? Is it one, two, or all?
Oh.
All. Very good. Excellent. All. Okay. They all have affinity. That means they all can bind. Now, which one does not have efficacy?
Antagonist.
Antagonist.
Very good. Okay. So very good. Antagonist has affinity. It binds, but it just blocks the receptor. It just blocks the receptor, so the endogenous ligand cannot combine to the receptor. It just blocks the receptor. It does nothing to the receptor, and so So again, this one I've said affinity, and we've said what affinity is, efficacy is. Now look at this. This is a full agonist. A full agonist is a drug that can give maximum response, maximum efficacy. Look at this. Look at the x-axis. As you increase the dose, you increase the response, whatever response that you're measuring. Okay, increases the response. You know why it stops here? Because a further increase of the dose will not increase the response. So it has reached its maximal efficacy. All right. Now you don't need to know the details of the experiments. Now these experiments are always done for drugs. The full agonist, by definition, has affinity, and produces 100% efficacy. Now look at this down here. Don't worry that it's a bit crowded, okay? Full agonist. Can you see that? Full agonist?
Yeah.
Oh, full agonist is partial agonist. So full agonist causes 100% efficacy. Any drug, and I mean any drug that causes less than 100% efficacy is known as a partial agonist. Even it causes 99% efficacy, it is still a partial agonist because we have very clear definition of what a full agonist is, and that is it must cause 100% or maximal efficacy. Antagonist, no efficacy. Okay, antagonist, no efficacy. Inverse agonist has, we call, it causes a response opposite to the agonist. So we say it's got a negative efficacy. That's the definition. All right. Inverse agonist causes a response. What response? Opposite to opposite to an agonist, whether full or partial. So we say it's got. So I said that maximum of full efficacy is known as efficacy equals to 1 or 100%, and so on and so forth. Efficacy less than 1 or less than 100%, zero efficacy for antagonist, and negative efficacy for inverse agonist.
Professor?
Excuse me, Prof.
Yeah, sure.
Yeah, go ahead.
So are there drugs that act as full agonists, or is that like a theoretical concept?
Say that again.
Are there drugs that operate at full efficacy, or is that like a theoretical concept?
No,
that,
no,
like, people are trying to work with?
No, we have full agonist. It's not theoretical. We have full agonist, and full agonist is reached when if you increase the dose, it will not increase. If say you're measuring a response to reduce to what shall I say, increasing the drug will not increase the response. It may increase the adverse effect. It's not it's not a theoretical concept. We do have full agonist. Okay.
All right. Thank you, Professor.
Sure.
Professor, for inverse agonist, is it 100% efficacy as well? But
inverse agonist we say is negative efficacy.
So any value from 0 to 100?
Yeah, it's got a negative value. It's got a negative value. It is used clinically, but we don't use it for its inverse efficacy properties.
Thank you.
All right.
Doctor, I have a question.
Sure.
So basically the inverse agonist still has efficacy, but it's just that it's in the negative zone, right?
Yes. Yeah.
Okay. Thank you, doctor.
Sleepiness, all right? But if you use an inverse agonist, it causes wakefulness. So you're right. Something must happen in the cell, right? But we just, because it causes opposite effect, and this is a relatively new concept. When I was a medical student, there was no such thing as inverse agonist. So things are coming much more these days, and it's exciting. So knowledge check for you guys. A 55-year-old man is seen in the clinic with a persistently elevated blood pressure. And he's diagnosed with hypertension. Okay. Now, before I do that, do you know what potency is? Do you know what is meant by potency?
Its effectiveness?
No, if efficacy is effectiveness.
The capacity.
The dose of the drug. You see, if a drug 5 milligrams, if I give a patient 5 milligrams, it reduces the blood pressure by 50%. Okay, follow me? 5 milligrams, it reduces blood pressure by 50%. For example, I have another drug which is, instead of 5 milligrams, I need to give 500 milligrams for the blood pressure to drop at 50%. So although they both drop the blood pressure by the same amount, 50%, one does it at a lower dose than the other. So we say the lower dose one has got a better potency or is more potent. In layman terms, people you always hear is stronger. Actually, they will, because you can reduce the blood pressure by the same percentage as the 500 milligram ones. Do you understand potency now? Yes or no?
Yes, Prof.
Okay, good.
Yes, Prof.
Professor,
Yeah.
Could you please repeat the definition?
Repeat potency.
Yes, the definition.
Okay, can I ask you guys something? I understand there's a lot of concept and I'm excited that you're asking questions. If we don't get to finish the lecture, all right, are you able to set another time? I don't mind. Saturday, Sundays, it's fine with me for me to finish the lecture. Is that okay with you?
It's fine with us.
Yes.
Okay, good.
Yes, Prof.
Then I like this because it's an interactive lecture. You can ask me anything, anytime. Okay, potency. Potency is a very important concept. Potency refers to the dose of drug A. 5 milligrams of drug A can reduce the blood pressure by 50%. All right. Drug B also can reduce the blood pressure by 50%. The difference is drug A does it at a much lower dose, 5 milligrams. Drug B has to do it at a higher dose, 500 milligrams. So we say drug A is more potent than drug B. Clear? Not clear? Repeat.
Yes. Clear, thank you.
All right, okay. So knowledge check on potency. The next slide. A 55-year-old man is seen in the clinic with a persistently elevated blood pressure, right? It's 150 over 95 or thereabouts, but it's high on 3 consecutive clinic visits and is diagnosed with hypertension. A decision is a calcium channel blocker. Now, a CCBA, calcium channel blocker A, in a dose of 5 milligram produce the same decrease in blood pressure as 500 milligrams of calcium channel blocker B. Now, I want you to tell me what the answer is. Which of the following predictions is most accurate? A, remember A is 5 milligrams. A, CCBA will be more efficacious than CCB. What is this? I've not changed, sorry. CCBA, just listen to me then. CCBA will be more efficacious than CCB B. CCBA, remember CCBA is 5 milligrams, CCB B is 500 milligrams. So A will be more efficacious than B. A will be 100 times more than that of B. A will have a wider therapeutic window than B. A will have a longer half-life than B. Which is the right answer? And I just
B.
told you this is a... Someone said B, right? B. Congratulations, B is correct because we just talked about potency. Now, I'm so sorry about the Y and the X and the A. Apparently, it was not changed. So the correct answer is B. A will be about 100 times more potent than B. Now, we cannot say about the other things because no information is given regarding the maximal antihypertensive response to either drug. Similarly, no information about half-life. We don't know the half-life. We don't know the safety margin. We don't know the therapeutic window. We don't know the toxicity. No information is provided, so you don't know. The fact that a given response is achieved A indicates that A is more potent than B. Okay, are you clear about potency?
Yes, Prof.
Good.
Yes.
That's good. Now we move on to LO2. Explain 4 mechanisms of drug action: receptors, carriers, ion channels, and enzymes. These are basically the ways that we know a drug acts. Okay. So let's look. There are 4 mechanisms of drug action. We've said that before. Okay, now look at this blue panel. The blue panel is all about receptors. Okay, and the blue panel has got a lighter blue panel which tells you the location of the receptor. It's at the surface or at the membrane of the cells. So receptors can be found on cellular membrane, cellular receptor. So there's surface or membrane receptors, and there's also intracellular receptors. So there are 3 types of surface membrane receptors, and we have to go through all 3. And there's only one for intracellular receptors. We'll also have to go through that. So surface or membrane receptors are ligand-gated ion channels, G protein coupled receptors, or receptors that are linked to enzymes, but they all involve receptors. Part 2 or number 2, intracellular receptors, they are drugs which requires to enter the cell to combine the receptors because the receptors are in the cell and it affects gene transcription. All right, so the surface membrane receptors is intracellular receptors. So how many, if somebody asks you how many types of receptors are there, you say 4, 1, 2, 3, 4. But the location is different for number 4. Non-receptor mediated mechanisms. Carriers, ion channels, enzymes. Now, students frequently get confused the difference between green panel and blue panel. But there's no reason to be confused because these ion channels here, the drug has to act through a receptor before this ion channels is activated. They have to activate the receptors first before the ion channels can open. Here, the ion channels open, the drug directly opens the ion channels and does not have to act via a receptor. All right? Okay, enzymes. Here, the drug has to act via a receptor. They have to activate the receptor before it can do anything to the enzyme. Here, non-receptor mediated or deactivate an enzyme. It does not have to go through a receptor. Do you understand that or not?
Doctor, can you repeat the non-receptor part? Sorry.
Okay, the non-receptor parts, there are three non-receptors, excuse me, carriers, ion channels, and enzymes. What is the difference between these ion channels here in the green panel and ion channels here in the blue panel? Difference is the ion channels in the blue panel, the drug has to act via a receptor in order to do something to the ion channels, in order for the ion channels to open or close. All right? But the ion channels here, the drug can itself binds to the ion channels straight away, directly binds to the ion channels and not have to go through a receptor. Is that clearer? Or you still don't understand?
Yeah, okay, thank you, doctor.
All right. Same thing with enzymes, okay? Linked to enzymes, they have to activate the receptors before the enzymes can be activated or deactivated. Enzymes here, no receptors involved. The drug can straight away go to the enzymes and do what it wants to do to the enzyme, okay? One goes through receptors and one does not need to go through receptors. That is the difference. So this is a location I was talking to you about. Some receptors, the first 3 receptors are found on the membrane, so we call them membrane receptors, or we call them surface receptors. They are one and the same thing. Doesn't matter what terminology you use, you are right. The other one is an intracellular receptor. So you see, membrane receptors is on the membrane. The intracellular receptor is in the cells. That means it's not in the membrane. So why is it so important? Why is it so important that we have to mention this? It's because when it is in the cell, it means the drug or the ligand has to cross the membrane. And yesterday in your pharmacokinetics lecture, what property of a drug, what property must the drug have in order to cross membranes?
Lipophilic.
Lipophilic.
Should be lipophilic.
Fantastic. Very good. Yeah, they have to be lipophilic. They have to be lipid soluble. Otherwise, it cannot go, right? They cannot cross and they cannot reach the intracellular receptor. So this one, they need not be lipid soluble. Why? Because it's on the membrane and it's very accessible. Now look, this is how agonist. I'm going to go through with you on this slide the key concepts. This cartoon depicts this part, follow me, this part is outside the cell, extracellular compartment. This is the cellular membrane. This is in the cell, intracellular compartment. Now here is the receptor. So we can call it a membrane receptor. We call it a transmembrane receptor because it goes across the membrane, or you call it a surface receptor. It doesn't matter to me. You are right. Any way you call it, as transmembrane, membrane, or surface receptors. All right. And this here is a ligand. And the ligand here is an agonist. All right. So we have a few agonists. Okay, these are agonists, as you can see here. Now, one of the agonists gets to combine with the receptor. Binding to this receptor will cause activation of the receptor. Yes or no?
Yes.
Yes.
Fantastic. Of course it can, right? First of all, it can bind to the receptor and we call it affinity. Therefore, this agonist has affinity to the receptor and you are right. It can cause receptor activation. You see, it activates the receptor. So drug receptor interaction will happen once agonists combine to the receptor. All right. Now, once it combines to the receptor, it activates the receptor. There will be cell signaling happen in the cell. We won't go through it now. We will go through it when we talk to you about the systemic lectures, for example, asthma lectures and all that. All right. So there will be, once it's activated, there will be cell signaling, and this will provide a clinical response which you see in your patient. Activate a receptor, an agonist, not that activates, an agonist activates a receptor, causes cell signaling, produces a response, and therefore it has efficacy. And this is true for full agonists and partial agonists, okay? So knowledge check. I want you to answer me. An agonist, A, has affinity towards receptors, yes or no?
Yes.
Yes.
Very good. Has no affinity towards receptors, yes or no? Wrong or right or wrong? Wrong. C, does not activate receptors, right or wrong?
No.
Wrong.
Wrong.
An agonist does not activate receptors is wrong. An agonist produces cell signaling upon drug receptor interaction, right or wrong?
Right.
Right.
Yes.
No efficacy, right or wrong?
Wrong.
Wrong.
Wrong. Very good. So you've understood. Any questions on this? Okay, if you think of questions, we can come back. Otherwise, we'll move on. Now, this is antagonists, okay? And we know antagonists are defined as drugs that has affinity. Has affinity, which means it can bind to a receptor, but it does nothing to the receptor. It does not activate the receptor. It does not stimulate the receptor. It just blocks the endogenous ligand from mediating its action. All right. So antagonist is actually a blocker of a receptor. So drugs that bind to a receptor but does not activate it to produce a response. For example, drug B. So drug A, we said, will produce a response, but if you use a drug B, there will be no response. Same effector organ, no response. Okay. Because this is just the principles that we're trying to convey to you. We understand there's a lot of concepts that you have to remember before you start your systemic lectures, like drugs used in heart failure, drug used in hypertension, drug used in relieving acute bronchial asthma. You will learn all that. These are just principles that you have to grasp. So an antagonist has affinity. I said all the drugs, okay, and full agonist or whatever agonist and antagonist, they all have affinity. They can bind to the drug. The difference is antagonist, no efficacy, it produces no response, right? So it causes no cell signaling, no response. So just a reminder, this is an agonist. It is just here, it just blocks the response, not like full agonist and partial agonist. Okay, how does it antagonize the same thing? Okay, this how does it antagonize a cell surface receptor? Agonist binds to a receptor. When an antagonist binds to a receptor, the agonist has a less chance of binding to the same receptor, or the endogenous ligand cannot bind to the receptor. The chances are less because there's a lot of antagonists, and antagonist wins, let's call it like that. It wins, it competes and it wins, and it combines to the, it binds to the receptor. But there are no drug receptor interaction. Therefore, no cell signaling happens, and therefore no response. And we say an antagonist does not have efficacy. It has affinity, but it's got no efficacy. Knowledge check. An antagonist has affinity towards receptor, right or wrong?
Wrong.
Right.
Right.
Right. It's right,
Oh,
okay?
right,
Because they all,
right.
yeah, affinity just means whether they can bind or not. That's cannot bind, all right? So an antagonist can bind. So it has affinity towards receptors. An antagonist, upon binding to a receptor, produces a response, right or wrong?
Wrong.
Excellent. An antagonist does not activate receptors, right or wrong?
Right.
Right. It doesn't activate the receptors, it blocks the receptors. An antagonist produces cell signaling upon binding to a receptor. Wrong. Doesn't cause any cell signaling. Okay. An antagonist has no efficacy, right or wrong? Right. It's got no efficacy. All right. So an antagonist has affinity but no efficacy. Now, once you know it does not have any efficacy, any efficacy, it has no efficacy, that means it has no cell signaling, that means it cannot activate the agonist. Is a repetition. Same affinity means it can bind, but it causes a less than 100% effect or less than 100% efficacy. Even if it's 99%, we call it a partial agonist. All right. Now you know you will know the implications tomorrow when the lecture when we talk to you about dose response curve. All right. So there's a partial agonist. Now, inverse agonist and summary of agonist and antagonist. Now, this is inverse agonist, which I showed you even in the earlier slide. It is just to illustrate to you. We don't have to go into details now. An inverse agonist causes opposite effect of a agonist. The example I gave you was an agonist, whether it's partial or full, causes sleepiness, but an inverse agonist causes wakefulness. That is the usual example. Now, this is a summary you can read on your own. Okay, efficacy is all about affinity and efficacy of agonists and so on and so forth. Now, this is a table that I have drawn up for you, but I want you to fill it up. All right, we won't go through this because it's everything that I've said before, and you can refer to your notes and fill it up. Affinity, I'll go through the first one. Affinity, is it yes or no? Full agonist will be yes or no?
Yes.
Yes.
Partial agonist?
Yes.
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 Not inverted agonist, sorry. Inverse agonist?
Yes.
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 Antagonist?
Yes.
Yes.
Yes, very good. So affinity is yes for all. And you please do all the others, okay? Because this is a summary slide. Now, I'm not doing this summary slide just because I like to work. I like to make tables. No, it is to give you the idea that you have to simplify things for yourself. Please do it. All right, that's how you study. Knowledge check. See, prior to clinical trials, and this is true for all drug development, okay, we have to do animal study. Now, an animal study was carried out to compare two new drugs. Forget about inotropic. Okay, drug A and drug B. They want to compare drug A and drug B, which is a better drug for heart failure. The heart failure drug that they have now is drug C, the current standard agent. They have this drug C. And drug C is a full agonist, maximum efficacy or efficacy of 1 or 100%. Now, you may be asking yourself, if it's already maximum efficacy, full agonist, why do we bother to look for other drugs? Well, we do that mainly because sometimes this drug C, the patients have to take it 4 times a day. So compliance is poor. Sometimes, so we have to develop new drugs which is better than drug C. All right. Now, which of the following statement is correct? Drug A is most effective. Drug A. Is it most effective? Right or wrong? Wrong, of course, because you see the efficacy is less than 100%. Here is 100% maximum efficacy. Now, what do you think drug A is?
Partial efficacy.
Partial, fantastic, excellent. Yeah, drug A is a partial agonist. Okay, so it cannot be the most effective. A partial agonist, because we have got better drugs which can give you better effects or more efficacy. Drug C is most potent. Which one requires? See, drug C and B, they are both.
B is more potent.
B is more potent.
Exactly. Drug B is more potent. So B is wrong. Now, see, this C should be here lah. What lah? Okay, sorry. So drug B is more potent than drug C. Drug B is more potent because you use a lower dose to achieve maximum efficacy. There, the dose is here. But C, the dose is higher. So drug C is more potent than drug B is more potent than drug C and more effective than drug A because drug A is a partial agonist. All right. Drug A is more potent than drug B. Okay, I'll just show you the answer. Right, you've already said the answer just now. Drug A, drug A produces 50% of its maximum effect at a lower dose. then either B or C, and thus is the most potent. A partial agonist is less efficacious than drugs B and C. So if you want a very efficacious drug, you want a very effective drug, you cannot use drug A. But if you want some minimal effect, you can use drug A. All right. So the answer is, this is wrong. The answer is C. Can you see that? Hello?
Yes, doctor.
All right, thank you. I'm so sorry about the mistake. Okay, explain four mechanisms of drug action: receptors, carriers, ion channels, enzymes. And I said that it is related for receptors, is related to its four main types. I want to see the time, whether we have time. Now we have only 4 minutes more. I'll continue until 10:15. What time is your next lecture?
10:30.
Okay, we will stop. Are you okay to stop at 10:20?
Yeah, we're fine.
Yeah, but you have to give me another time, all right? Because there were a lot of questions, and I'm really happy about you asking questions. It means that you're thinking, but I'm not able to finish the lecture because I don't want to rush through. So this is the same slide you saw before. We are now talking about the blue channels, the blue panel, all right? Now, ligand-gated ion channels through receptors, not receptor mediated, is receptor mediated. Ligand-gated ion channels. Receptors directly affecting the opening or closing of ion channels, meaning the drug has to go and has to bind to receptor, activate the receptor before the ion channels can open or close. These are the examples. And the time taken for this response to occur is very fast, milliseconds. And this is what I want to demonstrate to you. All right. So these are receptors. The yellow rectangles. The yellow rectangles are the ion channels. All right. Now, can you see this white thing here?
Yes, doctor.
Okay. That is the receptor site. Now the receptor site is on the ion channels, all right? So let us see what happens. Okay, so it binds to the receptor site on the ion channels, all right? If it cannot bind to this receptor, let's say this drug that we give is triangular shape and cannot bind to this receptor, the channel won't open. You understand? So we have to have an agonist. In this case, the illustration is with acetylcholine. It binds to the ion channels, and then, only then, the ion channels will open. And then you can have ion. Or repeat. Are you still there?
Yes, doctor. Doctor,
Clear?
could you
Not
when the ion channels open?
channels will open only when the drug, only when the ligand has bound to the receptor. Where is the receptor? It's on the ion channels. Now this yellow thing here, is the ion channels. Yellow thing here is the ion channels. All right. Now, in order to open the channels, the ligand or drug must bind to the ion channels. Now, I purposely drew it oval because I drew the receptor as oval. Now, if I were to show you a triangular drug, the triangular drug will not fit here. Fits. It's like a lock and key. It fits the ion channel, the receptor site. It binds to the receptor site where on the ion channels. Why? Because it's a ligand-gated ion channels. Okay. So now you see the channel opens because it is now activated. This ligand binds to the ion channel, activates the ion channel, and the channel opens. When the channel opens, the ions from outside can come inside. Sometimes we need to do that in order to elicit effects and a clinical response. Anyone? If anyone is not clear, you go back, discuss with your friends, and you can always come back to me. All right. Second one is G protein couple receptors. Now we're talking about G protein couple receptors. This is the agonist. It finds its way and binds to the membrane receptor or transmembrane receptor or surface receptors. Why is it called G protein? Because there's a G protein attached to the receptor. When the agonist combines to the receptor, it activates the receptor. When it activates the receptor will activate G protein. When G protein is activated, it will activate effector molecules, enzymes. I have not named the enzyme here because I didn't want you to concentrate, I think, on the enzyme here. So these are all cell signaling, okay? Remember I said when an agonist combines to a receptor, it stimulates the receptor. When it stimulates the receptor, there will be cell signaling happening in the cell. So this is what we mean by cell, a lot of things happening here. G protein is activated and G protein activates effector molecules, and effector molecules will cause. Okay, so the mechanism of G protein is called a signal transduction effect. You don't have to know that. It's a cell signaling mechanism. Cell signaling mechanism. So the pharmacological effects that it gives rise to is the clinical response that you want. All right, now this is a busy slide, but stay with me. We'll end. This is the last slide, okay? Because I don't think we should go beyond. I think you need a break. So the cell here, I've taken it as the example that I've put here is an airway smooth muscle cell. Okay, so this is an airway smooth muscle cell. Those of you who are asthmatic, who have asthma or have family members or friends who have asthma, be interested in this slide because the first few days, first few weeks of your time in medical school, you already know how they act. Airway smooth muscle. Now, in asthma, the airway smooth muscle will constrict. They will contract and constrict, and the person cannot breathe. All right. So now, what we want to do is we don't want the cell, we don't want the smooth muscle cell to constrict. We want it to relax and open up the airways. So we give a drug. When we give a drug, okay, it combines to the beta-2 adrenergic receptors. Where is the beta-2 adrenergic receptors located? On the smooth muscle cells. So this, depicted as receptor R, is beta-2 adrenergic receptors. Where is it located? On the membrane. Membrane of what cell? Of the airway smooth muscle cells. Okay, got that. So we have an agonist. The agonist combines with the beta-2 adrenergic receptors. And the agonist, those of you who have family members or who are okay, we still use salbutamol a lot in the clinics. All right. So because it can activate beta-2 adrenergic receptors, it is called a beta-2 agonist. So it activates the beta-2 adrenergic receptors, all right, which activates the G protein and activates the second messenger, which is adenylyl cyclase. Here, adenylyl cyclase. And what does adenylyl cyclase do when it's activated? It increases cyclic AMP or CAMP. All right. Now all these things, from the word cell until AMP, they all happen here. All right. So when there's increase in cyclic AMP, there will be relaxation of the smooth muscle cell. And that's a pharmacological effect. Relaxation of the smooth muscle cell. You see? When there's dilate, bronchodilation, and a person can breathe very easily. So you give salbutamol to a patient, all these things will happen in the cell, and the patient will have bronchodilation, and you are very happy, the patient is very happy because the clinical response that you see is the patient can breathe better. It relieves breathlessness that was due to bronchoconstriction. Have you understood this slide or not? Or do you need me to repeat? I'll repeat and then we'll stop. Guys, are you there?
Yeah, doctor.
Yeah.
Are you okay with this slide? You mean
Yes.
you may understand, but I don't expect you to remember. To remember and to understand is different. You understand, but you have to go back, read through it, and remember it, and digest it again. Okay? Are there any questions so far? We have to stop now.
Professor, which part of this comes under cell signaling?
Cell signaling is everything that happens after the receptor is activated. From G protein until AMP.
Thank you.
All right. Shall we stop now? Can you tell me, pardon?
Sorry, Prof, I have a question.
Yeah, sure.
May I check if antagonist is a competitive inhibitor? Is it the same?
Definitely. You see, if we use an antagonist of an adrenergic receptor, adrenergic receptor is the beta blockers. Can you see this? It's a beta receptor.
Yeah.
So if we block the beta receptors, do you think bronchodilation will happen?
No.
Yeah. What will happen?
The smooth muscle will stay contracted.
So if you give a beta blocker, beta blockers are given to treat high blood pressure. Okay. If you don't ask your patient, are you an asthmatic? You don't know the patient is asthmatic. You give a beta blocker, you may induce an asthmatic attack in the patient. Does that make sense to you?
Yeah, thank you.
All right. So can you please quickly check and tell me when you can have the lecture? There are a few more slides that I have to go through. Come on, guys. Are you checking?
I think tomorrow the medical students are kind of free, but I'm not sure if it's everyone.
As well? Actually, I don't mind giving separate lectures to dental students and medical students if you cannot find a time. Tomorrow, medical students, what time are you talking about? Let me see if I'm free at that time. What time are you talking about? I'm free in the afternoon. Are you free anytime in the afternoon? And by afternoon, I mean even 7 p.m. if you want. Okay, let me say this. Are you free at 5 p.m.? Are all of our dental students and medical students, are you free at 5 p.m.?
No, we have a lecture at that time.
Yeah.
Are you free? It's a long day for you. Are you free at 4 p.m.?
No.
Okay, when are you free?
I think we're only free on after 6:15 because tomorrow at 5:15 we have a lecture on applied pharmacodynamics too.
Oh, you have ECOS lecture then.
Yeah, so we have the so 7 p.m. onwards we should be free. If that's all right with you, doctor.
Are you okay with that?
I'm fine with it.
Pardon?
I'm fine with it, but I don't know if everyone else is okay with it.
Okay, can I leave it to you to check who is your leader? I wait for you to tell me. Okay. What I'll do is I'll try to switch with Ego. Or we'll do something. Just give me a time when you are free. If you cannot find a time when medical students and dental students are free, that's fine with me. I can just give a separate lecture to both sets of students. Okay, but I need to know who will let me know. Who is your batch rep?
I'm the batch rep for DT as well as Monica. Maybe we'll contact the ME batch rep and then we'll give you an answer, Doctor.
Somebody's talking, but I can't hear. I'm so sorry.
Sorry, Doctor. Can you hear me now?
Yes.
So I'm the batch rep for DT 121 as well as
Uh-huh.
Monica, and then we will discuss it with the ME reps, and then we'll get back to you.
Great. Okay, take down my number.
Oh, okay.
And WhatsApp me 013
all right.
391
391
3304.
3304.
Yeah, 013 391 3304.
All right. Thank you, Professor.
Right? Great. And if you can, you give me 2 alternative times, okay? Because then I can adjust my meetings if I have them. All right?
All right.
Okay, good. All the best. And yeah, keep those questions coming. All right. Bye, everyone. Have a nice day.
Thanks, Professor.
Thank you, doctor.
Thank you,
Thank
doctor.
you,
You're
Doc.
most welcome.
Thank you.
Thank you,
Thank you,
doctor.
Doctor.
Thank
Have a
you.
good day. Thank you,
Thank you,
Professor.
doctor.
Thank you, doctor.
Thank you, doctor.
Hello. Isatus, are you there?